Hi, welcome to today's episode of Guideline Review of the Week. Today, I have chosen a topic that I believe is quite important for places which have this disorder, that is sickle cell disease, endemic to them. Me, as someone who practices in Mumbai, we have a few pockets in Maharashtra state from where we get a lot of patients or a lot of females who have this disorder. Most of them already know that they have it, whereas few who have the sickle cell trait are diagnosed with the disorder for the first time in their pregnancy. And hence, it is very important for everyone to know this topic because quite often you'll be getting these patients, and the management of these patients is quite different from the way you manage any other types of anemia with which these patients present. So, welcome to today's episode. And today's guideline is something that I've not taken from a green top guideline because this used to be a green top guideline earlier. Sickle cell disease was one of the parts of the green top guidelines that are issued by the RCOG. But this is something that is again a part of RCOG, and that is British Society for Hematology guidelines. And in it, they have published this guideline. This is very recent a guideline. This has been published in the last 1 year, and hence you're getting the most updated version that you can get on this topic with all the evidences. So, welcome to today's session and let us proceed. So, when we talk of sickle cell disease, we have read a lot of it in our medicine postings and in our final year MBBS. There was not much that we had spoken about this disorder when it came to obstetrics, though, because a lot of its management is very specific. So, how is it caused? A basic thing that we have all learned multiple times, it is caused by the inheritance of the abnormal hemoglobin sickle cell gene, that is HbS. Now, as we already know that the inheritance is autosomal recessive. Hence, if I have a female and her partner, the male, and let us assume that the female has sickle cell disease. So she will have S and S, whereas the partner doesn't have anything. So I will just write it as N. N is normal. So when they have kids, they will have NS, 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 and again NS. So basically, all the kids will have sickle cell trait as a disorder. Whereas if I'm going to change even one gene from the partner and make it into an S, then I understand that at least two of my babies are now going to be affected. And hence, when I talk about this, now I have two babies who have sickle cell disease, just like the mother. So there's a 50% chance that the kids are going to be affected with sickle cell full-blown disease, and the other two are always going to have sickle cell trait. And hence, it is very important for people who are endemic to this region. If I'm going to be talking about the mother as well, herself being someone who has sickle cell trait, as is the cause in most of the cases, so again, one sickle cell gene and the other one being normal. In that case, there is going to be a 25% chance. So there is going to be a 25% chance of one baby having sickle cell disease, whereas one baby, there's a 25% chance that the baby will not even have trait, whereas the other 50% chances are lying with their baby or the fetus having sickle cell trait. And hence, it is very important that we screen these women for this disorder. And if the female has it, then also the screening of that partner is very essential. Apart from that, we also get nowadays a lot of combinations, and those combinations are ones wherein the sickle cell disease in itself is combined with other hemoglobinopathies like HbC hemoglobin or D hemoglobin or even HbE hemoglobin. We often also get nowadays cases with beta thalassemia trait with sickle cell trait. So this has been, I mean, I have personally been seeing this a lot nowadays. And yeah, this is also very common, and it just adds to the anemic part of that female. So, what is the pathophysiology and why should it be something that should concern me? So we have all read about the sickling test, wherein there is stick. The sickling is basically the cells become of the size or of shape of a sickle. Sickle is that instrument that a lot of farmers use. It is something that is shaped like this. So the cells become sickle shaped, and the test to diagnose it is known as the sickling test. So this is caused, it is all the symptoms of sickle cell disease are caused because of the polymerization of all these sickled RBCs. And these sickled RBCs, they are fragile and they are rigid. Now, such RBCs are they are faulty and defective, and they are going to be detected by a reticuloendothelial system that is present inside my spleen. And hence, whenever my spleen detects it, they are prone to developing hemolysis. Basically, they are going to be caught by the spleen, they are going to be sequestered in the spleen is a better word, and they're going to be broken down there. This will lead to rise of hemolytic anemia. And also, if at all these cells do end up bypassing that spleen, they are going to go and block my other normal blood vessels, and they are going to cause vasoocclusion. What we also call, as if it happens in a particular organ or several places, we call it vasoocclusive crisis. So they are going to cause blockages, they are going to block my vessels, and because of that, we get a lot of symptoms like acute painful crisis. Acute painful crisis में आता क्या क्या है? There is acute chest syndrome, very important. What happens is that all these blockages occur in the pulmonary vasculature. So whenever the pulmonary vasculature is blocked, my lungs, my pleura, all of them get no blood supply. So there is ischemia to my pulmonary parenchyma, to my lung parenchyma. This leads to the release of hypoxic factors and inflammatory factors, which lead to pain. Also, apart from that, apart from just the painful part of it, there can also be an increased risk of pulmonary hypertension, because obviously, if there are going to be blockages in the pulmonary vasculature, there is going to be an increased blood pressure inside my pulmonary capillaries. There is a risk of stroke, ischemic stroke, because if this is happening in the cerebral arteries, then there is going to be a risk that those blockages are going to lead to ischemic stroke. There is possibility of renal dysfunction if my renal arterioles are blocked, retinal disease if my retinal vessels are blocked, leg ulcers if the peripheral, if the end arteries that are present in my lower limbs are blocked, then it will lead to ulcers because of ischemia and necrosis of the topmost layers of skin. Cholerithiasis, a very significant part which is formed because of blockages to the biliary tract. And finally, a very bad part of it is avascular necrosis of the hip and several joints. So basically, all those vessels that are supplying those major joints, especially the acetabulum at the hip joint and the head of femur. At that point, because of that vasoocclusion, there is going to be complete necrosis of that joint, which will necessitate a complete joint replacement. And hence, these are all the what I'll say spectrum of things that can happen because of the vasoocclusive part of this disorder. This is completely separate from the hemolytic anemia and the hemolytic part that is anyway being caused because of the sickling of those cells. Apart from that, now that we know that because of these blockages and sickling, all these cells just stick together, there is also an increased chance of venous thromboembolism. Now, anyway, women who are pregnant, they have an increased amount of fibrinogen in their body. There is also increased production of all the coagulation factors because of increased estrogen during pregnancy. This leads to a hypercoagulable state in pregnancy. Now, hypercoagulability, if I'm going to be combining with sickle cell disease, there is an increased risk of venous thromboembolism that can occur. So, DVT, deep vein thrombosis, and even embolization to the major vessels like pulmonary embolism increases in these patients. And hence, the possibility of venous thromboembolism is almost 1.5 to 5 times greater than the normal population. They also require blood transfusion, obviously, because they are having hemolytic anemia or admission to the critical care unit. The blood transfusion not only helps in correcting the anemia, but it also helps in replacing the faulty RBCs that are present in your circulation. Although the blood transfusion that I'm getting from outside, even those cells will have a life of around 90 to 120 days since the time they were collected. They are going to break down after a point of time, as is the physiological process with RBCs, and I'm going to I'm going to require recurrent transfusions, which is often the case in patients with sickle cell disease. These women are also very likely to deliver before 37 weeks of gestation, and the babies are going to have a reduced birth rate. They are going to be of low birth rate. The reason again is that all these blockages, if they occur in the placental vessels, the blood supply to the baby is blocked, and because of which the growth of those babies is hampered. Often because of this fetal growth restriction or intrauterine growth restriction, IUGR, it necessitates delivery before even term, that is 37 weeks, is reached. Obviously, these all things are more common in sickle cell disease, a proper sickle cell disease rather than sickle cell trait or combined hemoglobinopathies. But overall, the risk is increased in all types, including sickle cell trait and combined hemoglobinopathies. Also, apart from it, there is an increase in maternal morbidity and mortality. Why mortality? Because DVT हो रहा है, venous thromboembolism हो रहा है, those can be fatal events. Preeclampsia क्यों हो रहा है? Because all those changes of blockages in your placenta are leading to hypoxic factors being released. Hypoxic factors are soluble FMS like tyrosine kinase and soluble endoglin. Now, you have read these factors when you read about preeclampsia, and hence preeclampsia is very common in patients who have sickle cell disease. Again, if the blood supply is completely stopped, the baby can die inside the uterus. Of course, we already spoke about preterm delivery and infants or babies that are small for gestational age that are low birth weight. So, now that we have learned कि क्या क्या problems आ सकते हैं in pregnancy, how do I take care of these women? First of all, they need to be made aware whenever they are diagnosed with it that the time they conceive or whenever they plan to conceive, they should be coming to me much prior to their conception. Why? Because of preconceptional counseling is very important on several fronts. So, what do those aspects that need to be discussed include? First of all, preconception folic acid supplementation is very important. You have to supplement them with folic acid, and also all the medicines that she has already been taking. I'm going to be discussing all the medications. So all the significant medications which can have teratogenic effects need to be spoken about with her, and they need to be stopped or changed to other better alternatives that are not teratogenic. So what all preconceptionally I need to do? First of all, the genetic screening. As I've already discussed कि partner अगर हो तो क्या हो सकता है. So in those cases, we have to know that women who already have sickle cell disease and यानी S and S जिसकी हमने पहले बात की थी. So if a female is already having sickle cell disease, full blown disease, if she has a partner who is also a carrier of either beta globin variant, that can be beta thalassemia, or of sickle cell trait, it needs to be spoken about. Because अगर वो trait में उसका कुछ ये भी रहा, if there is a possibility that the person that she has married is coming from the same region as hers where these disorders are endemic, then there's a 25 to 50% chance that the baby might be affected with the same disease. So as we have already spoken that there might be as high as 50% increased risk in each pregnancy of having a child with a sickling disorder. Hence, they need to be counseled better. And if the partner does end up having one of those traits or the disease himself, then pre-implantation genetic diagnosis has to be done. So basically, they have to conceive by using ART, assisted reproductive technique, IVF से उनको conceive करना है. And before you do IVF, before the embryo is given inside the female's uterus for implantation, I have to test that embryo whether that embryo also has these genes present in it, and only the embryos which do not have the gene for sickle cell disease have to be implanted, and hence pre-implantation genetic diagnosis is very important. Apart from that, these women need to be mentioned or they need to be told of what are the complications that she might face during her pregnancy. So first of all, an early assessment of the renal dysfunction and cardiopulmonary disease has to be made. Renal complications can occur in almost 60% of the women who have sickle cell disease in their lifetime, and the reason is there is glomerular hyperfiltration microalbuminuria. So now because of all those arterioles being blocked, the vaso-occlusive part of sickle cell disease leading to the changes that occur, there is podocyte dysfunction. Those podocytes which are present, they lead to podocyte dysfunction, and there is protein that is seen in the urine of these women from a very young age, and hence they often develop chronic kidney disease, CKD, whenever they grow up. Now, CKD in itself is a very high risk factor for pregnancy. It can lead to an increased chance of preeclampsia, intrauterine fetal growth restriction, and even fetal deaths. The mother's her own health can deteriorate very rapidly if she is having CKD and she conceives. Prior to pregnancy, these women should also have their blood pressures measured because she might be having chronic hypertension, and their creatinine and urine protein has to be evaluated. It has to be seen whether she has significant protein urea. Antihypertensives, these women, because of all the vaso-occlusive crisis, they can end up having hypertension. So if her BP is above 130/80, then she has to be started on, we do not wait for 140/90. Even if it is more than 130/80, we have to start them on antihypertensive agents. Apart from that, a 2D echo has to be done to see if she has pulmonary hypertension and ventricular diastolic dysfunction, because early cardiac death is very common in these women, and hence a preconceptional 2D echo is very important. Now, when I talk about the medications that she has to be taking, folic acid is a must-have medication. It has to be taken in doses of 5 milligram per day, 3 months prior to conception. Apart from that, vitamin D deficiency is very common in our ethnic population anyway, and hence they should be given, the dose of vitamin D that should be given is around 5 to 10 microgram per day. If she is yet to conceive, this is the pregnancy dose. If she is yet to conceive, then she can even be given 60,000 units per week for 6 to 8 weeks. So basically, this restores all her vitamin D stores for the next 1 year at least. So this can be given if she is yet to conceive, but if she has already conceived, then this is the dose of vitamin D that should be given. This mega dose, this huge dose should not be given during pregnancy. Apart from that, these women, because of the splenic sequestration that happens, even the splenic vessels are blocked because of those vaso-occlusive part की वजह से even the splenic vessels are blocked. Now, whenever the splenic vessels are blocked, इसके वजह से हो सकता है asplenia, or what we can also call as auto splenectomy हो सकता है, wherein the body has in itself blocked of the spleen and rejected it. इसके वजह से the spleen का major function, that is also immunity, and it protects us against all the capsulated organisms. So three important capsulated organisms, which includes Neisseria, Streptococcus pneumoniae, and Haemophilus influenzae. Our body is very susceptible to these infections. These are three major capsulated organisms. Hence, in bachus, you should be giving penicillin prophylaxis, but for adults, there is no use. Hence, vaccination is something that is very important, and pneumococcal vaccine, which is given for Streptococcus pneumoniae, should be given at least every 5 years, whereas Neisseria meningitidis, जो meningitis का आता है, that should be given at least 1 to 2 yearly, and Haemophilus influenzae has to be again given annually. So, Streptococcus pneumoniae जो है, it has to be taken. Pneumococcal vaccine जो आता है, so for Streptococcus pneumoniae, the vaccine is 5 yearly. For Neisseria meningitidis and Haemophilus influenzae, जो meningococcal vaccine और influenza का seasonal vaccine आता है, it has to be taken yearly by these people. Because उनका spleen का function is not great, it is suboptimal, because पूरा उसका जो functioning है, that is going wasted for the hemolytic part of sickle cell disease. Hence, these women will have their immunity completely impaired. And if at all this female, because of blockage to the splenic vessels, she has already had autosplenectomy or a surgical splenectomy has been done, then so definitely these women merit these vaccinations. So the status of the vaccination has to be checked prior to conception. Now, these women are often going to be having pain crisis, as we have already spoken. So, what are the safest analgesics that I'll be giving? The safest analgesic, of course, is paracetamol. I have to preferably not give them opioid analgesics and even NSAIDs. And देना है तो सिर्फ paracetamol is the ideal way to manage them. If at all need arises कि मुझे NSAID देना है, they should be given with caution only between 12 and 31 weeks. Why after 31 weeks it has to be avoided? The reason being, now all these NSAIDs, they block prostaglandins. उनका काम ही है cyclooxygenase को block करके prostaglandins को block करना है. When prostaglandin is blocked, what happens? Now, prostaglandin is a very important inflammatory marker or a cytokine that keeps the ductus arteriosus inside that baby's heart open. Duct dependent circulation is a very important process that goes inside the mother's uterus, whereas when the baby is delivered, it closes within a month or two. But if this closes when the baby is still inside, then the baby will have pulmonary hypertension and it can even have death. So premature closure of the PDA can occur if those prostaglandins are not available. These NSAIDs will cause exactly that. Diclofenac, ibuprofen, mefenamic acid, ये सब जो है, They will block all those prostaglandins that are produced that are useful for keeping the baby's ductus arteriosus open, and hence a premature closure of the ductus arteriosus will be initiated. Hence, it is preferably avoided after 31 weeks and before 12 weeks because there is a theoretical risk of teratogenicity. It is preferably avoided. Apart from that, there are two important drugs that these women take, and that is एक तो ACE inhibitors है, and the other one is hydroxycarbamide. Now you would think, what is hydroxycarbamide? I've never heard of it. It is nothing but hydroxyurea, the other name for it. So ACE inhibitors are very important because these patients are often, when they become adults, they are known cases of chronic kidney disease. Chronic kidney disease के साथ आता है hypertension. So to control hypertension and also to work on that chronic kidney disease, these patients are known to be taking ACE inhibitors. ACE inhibitors or even angiotensin receptor blockers. But these drugs are teratogenic. इससे होता है fetus में renal artery stenosis और even renal agenesis. So baby का जो kidneys है वो बनने से रुक सकता है, and hence these have to be discontinued prior to pregnancy, and it has to be shifted to any other antihypertensive. Apart from that, these women who are taking hydroxycarbamide or what I just mentioned as hydroxyurea. Now, what is the work of hydroxyurea? Hydroxyurea का ये काम है कि अपने में जो HbA होता है, which is a normal adult hemoglobin, it gets converted to HbF. Rather than converted, the production, I would say, of HbF increases once the patient starts taking hydroxyurea. Now, what is the difference between HbA and HbF? HbA जो हीमोग्लोबिन ए है उसके लाइफ से बहुत ज्यादा लाइफ है हीमोग्लोबिन एफ का. सो वेन एवर एन आरबीसी के अंदर का हीमोग्लोबिन जो है दैट इज गोइंग टू लास्ट लॉन्गर. तो जो भी उसके बॉडी में नॉर्मल एरिथ्रोसाइट्स जो आरबीसीज बचे हुए हैं उनमें ये हीमोग्लोबिन बहुत लंबे टाइम तक चलेगा, जिसके वजह से दी ऑक्सीजन कैरिंग कैपेसिटी वोंट बी दैट डिक्रीज्ड एज इट वुड हैव बीन इफ इट हैड हीमोग्लोबिन ऑफ द एडल्ट एचबीए अगर होता. तो बेसिकली वो एडल्ट में हीमोग्लोबिन एफ, आई एम टॉकिंग अबाउट एडल्ट्स नॉट द बेबी, हीमोग्लोबिन एफ का कॉन्सेंट्रेशन बढ़ाता है इन द बॉडी सो दैट द आरबीसी का लाइफ कैन बी प्रोलॉन्ग्ड. इट ऑल्सो हैज सम एक्शन ऑन द आरबीसी का सेल मेम्ब्रेन वेयर इट मेक्स इट टाइट इनफ to be resistant to sickling. Hence, hydroxyurea is a very important drug that these patients are often taking, but unfortunately, it is teratogenic, and hence it has to be stopped 3 months prior to conception. But a lot of women often end up conceiving when on hydroxyurea, so you have to preferably stop it if possible. But the problem is once you stop it, ये HbF जो है वो बनने का फिर से बंद हो जाएगा and इसका बढ़ना फिर से बढ़ जाएगा, and the patient might again have acute painful crisis, acute chest syndrome, and hence the risks and benefits have to be weighed upon to see रोक सकते हैं या नहीं. But preferably it has to be stopped 3 months prior or whenever pregnancy is diagnosed. Apart from that, now that the female is having hemolytic anemia, all that hemoglobin उसके body में जो भी RBCs are, they are breaking down and all the hemoglobin is lying out in the open. Hemoglobin is made up of iron. So in these women, all because of that hemolysis that is occurring in the spleen, there is a lot of iron that is just lying freely inside the blood. And hence these women are often women who have iron overload. अनफॉर्चुनेटली ये आयन ओवरलोड को कम करने के लिए जो आयन चिलेशन लगता है, व्हाट इज चिलेशन? चिलेशन इज बेसिकली वी गिव अ ड्रग, दैट ड्रग विल बाइंड टू द एक्सेसिव आयन एंड इट विल बी एक्सक्रीटेड फ्रॉम द बॉडी बाय बाइंडिंग टू इट. सो एक्सेसिव आयन इज रिमूव फ्रॉम द बॉडी, बट अनफॉर्चुनेटली इट इज नॉट recommended in pregnancy because the safety is not known and they are known to be potential teratogenics. The most common drug or the most important drug that we know of which is used as a chelating agent is desferoxamine. So desferoxamine is contraindicated in pregnancy. So prior to conception, these women have to be checked in their body for iron overload. There are two ways of checking it. हम लोग एक तो एक liver का scan करते हैं to see उसमें iron का load कितना है, and we also do cardiac MRI to see if there is any cardiac iron overload. So myocytes जो होते हैं, मायोकार्डियल के जो ये रहते हैं सेल्स होते हैं उसमें there is settling of iron if there is iron overload in the body. So a cardiac MRI is done and also liver का scan is done. There is a very special scan that is done to see if the female is having iron overload. A very similar thing is done in beta thalassemia. I'll be discussing about beta thalassemia next week in the next guideline, that all the patients have to be optimized on the iron overload front prior to conception by doing these two scans of the heart and of the liver. Those two scans I shall be mentioning in the next week's guideline review. So all these women who have been diagnosed need to be mentioned, all of these. And if it is known that even the partner is affected, then a prenatal diagnosis, if she doesn't come to me prior to conception, then a prenatal diagnosis by either CVS or amniocentesis is done to see whether the baby is having sickle cell disease. Though in India, sickle cell disease is not often, MTP is not often done, but I would recommend that MTP should be carried out because the baby will have a very poor quality of life once it is born. Because people with sickle cell disease often keep on having this painful crisis. They are having an increased risk of all the complications that we spoke of. Hence, either amniocentesis or CVS has to be done. Nowadays, studies are on to do NIPT, non-invasive prenatal diagnosis, so that जो cell free DNA होता है, इसका मतलब ये है जो बेबी का सेल होता है उसके अंदर जो डीएनए रहता है वो मदर के बॉडी में आके फ्रीली फ्लोट होते रहता है. सो मदर के बॉडी में अपार्ट फ्रॉम हर ओन सेल्स एंड हर डीएनए, इट आल्सो हैज फीटस का डीएनए दैट इज फ्रीली फाउंड इन द बॉडी. सो ये सेल के बिना सेल फ्री डीएनए जो है, वी कैच इट एंड वी स्टडी इट. We study the fetal DNA to know whether this baby is having any disorder or not. So this part of knowing whether the baby has sickle cell disease through cell-free DNA is still under research, but it has shown good results, and within the next few years, we will have it available as a method to know whether the baby has screening positive for sickle cell disease. In those cases, we need not do an invasive procedure like CVS or amniocentesis. Apart from that, we have already spoken that NSAIDs have to be avoided. Now, the most important part is pregnancy-induced hypertension. Now, these women, as we have already spoken, because of the increased inflammation in the body and all the vaso-occlusive crisis that occurs in the placenta, there is an increased risk of pregnancy-induced hypertension and preeclampsia. Pregnancy-induced hypertension is not a term that we use now. Preeclampsia is a better term. Hence, to avoid this, we recommend 75 to 150 milligram, which is low dose aspirin, be given to these women from 12 weeks of gestation till 36 weeks of gestation. This is known to either delay or even prevent preeclampsia from occurring. ये जो aspirin है, that is going to reduce the inflammatory state, and also it is going to reduce the adherence of platelets together, so the circulation, the RBCs will be able to move much more freely inside the placenta, and hence aspirin is recommended. What does low aspirin do? Low dose aspirin, which is 75 to 150 milligram, it inhibits just thromboxane A2. Now, thromboxane A2 is a vasoconstricting agent, whereas it doesn't inhibit prostacyclin, which is a vasodilator agent. So, ये specifically जब vasoconstrictor को inhibit करता है और vasodilator को spare करता है, then the eventual action is vasodilatation. ये vasodilatation की वजह से the hypoxia that was occurring because of the vaso-occlusive crisis of sickle cell disease, this doesn't happen, and hence preeclampsia can be delayed or prevented in patients with sickle cell disease by taking aspirin in low dose from 12 weeks of gestation till 36 weeks of gestation. Apart from that, because of these vaso-occlusive crises that we know of, there is going to be fetal growth restriction. So an ultrasound has to be done every 4 weeks to check for interval growth. Interval growth यानी दो scans के बीच में बेबी का कितना growth हुआ है, ये देखने के लिए from 24 weeks till term you have to be doing every monthly ultrasound to know the fetal weight. Now talking about blood transfusions, as I've already mentioned, that why is blood transfusion important to these women? Because inside their body they have affected RBCs. उनके जो RBCs they are completely affected, and affected है क्योंकि उनके sickling है, उसके अंदर का hemoglobin is HbSS. Now, if this female is receiving normal blood from a normal person, definitely it is going to help her by I'll say by replacing the HbS wala affected blood in her own body. Hence, if transfusion is needed, these women have to be given ABO compatible extended RH and KEL match, basically CMV negative, that is cytomegalovirus negative, which is ensured by all our labs anyhow. Also, no red cell antibodies have to be present. It should be negative for that. There are discussions, there are studies that say that we should be giving prophylactic transfusion. Prophylactic transfusion मतलब ना patient को anemia है और ना ही patient को acute painful crisis है. So is there any role of giving prophylactic transfusion? Yes, there is. We can just give it before she has an acute painful crisis or she has anemia. It can be considered, but you have to understand that you have to prevent overload in these women, because these women are known to be hypertensive. These women are known to have renal CKD, that is renal affection as well. So ये CKD के patients में, hypertension के patients में, you wouldn't want to overload them with more fluid बाहर से IV line से. Hence, you have to consider all these aspects. किसमें दे सकते हैं ये prophylactically? In women who have previous or current fetal problems that had occurred. So पुराने baby में या पुराने pregnancy में she had acute chest syndrome, acute painful crisis, or her baby had intrauterine growth restriction, or even intrauterine fetal demise. So in women who have history of all these things, or women who were on hydroxyurea for severe disease, but now it has been stopped because of her pregnancy. So in these women जिनमें ये relapse हो सकता है acute painful crisis का, because we have stopped hydroxyurea, these are patients who should be considered for giving prophylactic transfusions. Women who are already receiving long-term बहुत टाइम से transfusions for stroke prevention उनकी normal अगर उनके body में आएगा blood, so it won't lead to vaso-occlusive crisis. They should be continued with regular transfusions throughout the pregnancy. Pregnancy shouldn't be a reason why you stopped doing this. Now, ये सब तुमने किया, yet that female presents to you with acute pain crisis. Now, it has been known that pregnancy is associated with an increased risk of acute painful crisis. Why? Because your pregnancy is anyway a state of hypercoagulability. I have already mentioned that. इसकी वजह से ये जो sickling है, ये सब तो और बढ़ता है, जिसकी वजह से all these vaso-occlusive crises can occur more frequently. So what are the reasons? One of the reasons is already hypercoagulability. The other one is dehydration. These women in first trimester, all the women in first trimester often have hyperemesis gravidarum. They even have nausea and vomiting of pregnancy. Because of this dehydration of their body, उनके blood का viscosity और बढ़ता है, because the fluid that she is losing through that vomiting, it leads to even more viscosity of her blood. ये viscosity बढ़ने की वजह से with already affected cells inside, ये sickling जिनका हो रहा है, this leads to increased vaso-occlusion. It also worsens the anemia and is related to increased iron requirements and red cell turnover. Apart from that, we have already spoken that procoagulant hypercoagulable state of pregnancy predisposes to the vaso-occlusive disease, and also there is an increased risk of infection. Why infection, especially urinary tract infection and lung infections? Because unka immunity is affected. Why is the immunity affected? Because these women have a spleen that is not functioning as well as it should have. Hence, these women are prone to having infections every now and then. In fact, it is recommended that women who have sickle cell disease need to be tested for urinary tract infection every single month from 24 weeks of gestation. I will show that to you at the end of this topic on at what gestation you have to do which investigation for these women. Delivery, which is again a physiological challenge, which is something that causes a lot of load on that female, can lead to increased risk of dehydration, because these women जो cesarean होता है, vaginal delivery होता है, they end up having long periods of nil by mouth. They don't eat or drink anything, जिसके वजह से there can also be hypoxia, anemia, and overexertion. These women will be exerting. These women will be exerting during labor. Hence, this can lead to a higher increased incidence of vaso-occlusive crisis. ये vaso-occlusive crisis का सबसे पहला complaint रहेगा that these women will have pain. So if the female is having pain, then mild pain has to be corrected with just rest, fluids, and paracetamols. Fluids Q, already I've mentioned, a lot of the precipitating factors are related to dehydration, increased viscosity. So the first rule of management for managing the pain of women with acute crisis is to give them fluids, to give them normal saline, to ask them to have rest, and to give them paracetamol. नहीं हुआ तो weak opioids can be considered. NSAIDs have to be used with caution. We have already spoken upon it. And if a female is requiring a very strong opioid therapy, something like tramadol is something that she is requiring very frequently, then these women have to be admitted, and the analgesia has to be administered within 30 minutes of arrival to the hospital, because the pain can be very bad. For severe pain, we can even consider morphine के analogs जो मिलते हैं, and it can be given in any route, that is oral, subcutaneous, or intravenous route, depending on how the female is taking her or is able to bear the pain that she is having. Apart from that, पूरा ऑब्जर्वेशन करना है। देयर इज अ म्याओ स्कोर। म्याओ स्कोर इज बेसिकली मॉडिफाइड ऑब्स्ट्रक्टिव अर्ली वार्निंग चार्ट। इसमें भी मेजर द पेशेंट जनरल कंडीशन, द पल्स, ब्लड प्रेशर, चेस्ट रेस्पिरेटरी रेट, S1 S2 है या नहीं, एंड वी सी वेदर इट इज क्रॉसिंग द अलार्मिंग लिमिट। सो बेसिकली अगर पल्स 60 के नीचे जा रहा है या फिर 100 के ऊपर जा रहा है, बीपी इफ इट इज गोइंग बियॉन्ड द रेंज या फिर कमिंग बिलो 90 60, ये चार्ट में दिया रहता है, एंड वी हैव टू टिक इट एंड सी वेदर इट इज गोइंग इन अ डेंजर जोन। सो उसमें सिस्टोलिक एंड डायस्टोलिक ब्लड प्रेशर मेजरमेंट होगा, पल्स, रेस्पिरेटरी रेट हैज टू बी मेजर्ड, द टेम्परेचर एंड ऑक्सीजन सैचुरेशन हैज टू बी measured. The fluid status has to be assessed and dehydration has to be totally avoided. Intravenous fluids have to be given to maintain adequate hydration. We have already mentioned that. Apart from that, because of this painful crisis, अगर chest में blockages आने शुरू हो गए, the functioning of the lungs will be impaired and these women will have hypoxia because they are unable to carry out oxygenation. Oxygen क्यों नहीं हो रहा है? क्योंकि उनका जो capillaries था, they are getting blocked because of the vaso-occlusive crisis. Once these capillaries are blocked, the gaseous exchange is going to be affected, and hence oxygen levels will start falling often below the baseline or below even 95%. Whenever this happens, you have to suspect acute chest syndrome or even worse, pulmonary embolism. So first of all, oxygen लगाना है. You have to send tests to see whether it is pulmonary embolism. D-dimer भेजना है. If required, you will have to do a 2D echo and CT pulmonary angiography to rule out pulmonary embolism, because acute chest syndrome can be treated immediately by giving fluids and giving analgesics, whereas pulmonary embolism will require aggressive anticoagulation का treatment with heparin to ensure कि वो embolism वहां से निकल जाए. It can even require thrombolectomy. So you have to ensure that satisfactory oxygenation is maintained. Whenever these women are being assessed for infection, whenever these women are having acute chest syndrome, they have to be assessed even for infection because of necrosis of the lung parenchyma. There is an increased chance कि वहां पे anaerobic bacteria रहने शुरू करेंगे. So culture of the sputum has to be done. Obviously, urine culture तो हर बार करना ही है. Chest X-ray should be done if she has any abnormalities or if there is hypoxia, to see if there is any atelectasis, if any part of her lung has collapsed because of the ischemia that is occurring. WBC counts are often going to be raised, and this female is going to be febrile because of this acute condition. These women also need to be given thromboprophylaxis because ये condition precipitated इसलिए हुआ है क्योंकि उसके body के अंदर viscosity बढ़ गया है. Increased viscosity is again going to lead to increased risk of venous thromboembolism, and hence thromboprophylaxis has to be given. How do you manage a patient who is having acute chest syndrome? Obviously, you have to manage it with the help of an intensivist. सबसे पहले देखना है कि फीवर है, रेस्पिरेटरी सिम्टम्स उसको कोई है, डिस्निया है, इज शी हैविंग एनी न्यू consolidation on the chest which can lead to a suspicion of even pneumonia. So other diagnosis should not be ruled out. Obviously, the biggest differential diagnosis for acute chest syndrome is always going to be pulmonary embolism. So chest X-ray करना है और arterial blood gas का study करना है to see whether any hypoxia is setting in. In these women, you have to send blood culture क्योंकि फीवर के बाकी के कोई causes की नहीं देखना है, because these women are impaired in their immunity. Immunity impair हो रहा है, so blood culture, urine culture, sputum culture has to be sent. Nasopharyngeal aspiration swabs have to be sent. The management is very easy. Apart from sending these investigations, pain relief with paracetamol has to be given. Antibiotic therapy has to be started if any bacterial or viral infection is suspected. So, a broad spectrum antibiotic like azithromycin and oseltamivir, which is a respiratory antiviral drug, has to be started. Blood transfusion is a mainstay. It should be considered if the female, especially, is hypoxic. When you give blood transfusion, those bad RBCs of which are affected by HbS hemoglobin are replaced by the good RBCs, and this helps in restoring the blood supply to the affected parts of the lung. Even an exchange transfusion can be required wherein you replace the female's entire blood with a बाहर का blood so that उसके body के जो भी HbS वाले blood cells है वो temporarily निकल जाए पूरी तरह से body से. Apart from acute chest syndrome, other acute emergencies can be an acute stroke, which is a medical emergency. In these women, rapid exchange transfusion can help in reducing the possibility of long-term neurological damage. Acute anemia in these women is not just, remember, hemolytic anemia will cause chronic anemia, whereas acute anemia can be because ये female का कि immunity is impaired, so she is susceptible to all the rare viral infections, all the opportunistic infection. उसमें से एक आता है parvovirus B19. Now, parvovirus B19 is going to cause an aplastic crisis wherein it goes and affects your bone marrow. So all your bone marrow में जो भी RBCs बन रहे थे, they are going to be affected, and all the RBC ka production is going to stop down completely. Hence, a reticulocyte count should be done to see if there is reticulocytopenia as well. If the reticulocytes are also low, then you have to understand. Now remember, hemolytic anemia जब होता है, तो production तो और बढ़ जाएगा bone marrow से to replace the broken RBCs. Hence, reticulocytes will increase. But if the reticulocytes are itself low, then you have to understand that the bone marrow is in itself affected. Hence, that should point towards parvovirus B19 infection. The problem with parvovirus B19 is also vertical transmission to the fetus, and it can be teratogenic. Hence, a review has to be made with a fetal medicine expert. So, what are the recommendations whenever a female is admitted? Now, you have to understand that all women who have sickle cell disease, not sickle cell trait, only sickle cell disease, have to be given low molecular weight heparin from 28 weeks of gestation until 6 weeks after delivery. So, all the women, whether they have any other high risk factors or not, have to be given from 28 weeks of gestation till 6 weeks after delivery. You have to be started on thromboprophylaxis, because that 28 weeks ke baad ka period is the main period when the hypercoagulability increases even more. It peaks during the time of your delivery, and hence you have to be adequately covered with LMWH. So it has to be started. Whereas if a female is having any other risk factors like hypertension or chronic kidney disease, then the prophylaxis should start from the beginning or from the first day of pregnancy. If the female is admitted to the hospital for either vaso-occlusive crisis, yani acute chest syndrome or something, or even something like hyperemesis gravidarum, so every time she is admitted in the ward, she is going to be lying in her bed. There is impaired mobility, where basically the patient is not mobilizing much. Plus, a female is admitted for something. The reasons for admission for a patient with sickle cell anemia mostly are painful crisis. ये painful crisis के time पे the females vaso-occlusive part is increased, जिसकी वजह से body जिसका यही meaning है उसके body में the viscosity is very high. These are periods when she can have a deep venous thrombosis. Hence, whenever a female with sickle cell disease is admitted for any indication, you have to start them on LMWH. Apart from that, all the women, irrespective of complications, have to be kept on LMWH after 28 weeks of gestation. Finally, coming to the last part of the topic, around the time of birth. At what time do you deliver them? Now, remember that these women often have preeclampsia and hypertension. So, these women have to be induced at around 37 weeks anyhow. But if they do not have all of it, then 38 to 40 weeks is an ideal time to prevent the complications of delayed or post-term pregnancy. But unfortunately, a lot of women do not reach this part because the risks of abruption, unexplained stillbirth, preeclampsia, and peripartum cardiomyopathy are really increased in these women. So these women end up having a delivery before 37 weeks. We have to induce or we have to do the cesarean section way before 37 weeks. So reaching till 38 weeks is very far from ideal. These women, कुछ नहीं तो उनको placental insufficiency आ ही जाता है. They have fetal growth restriction, and because of that, we have to anyhow induce them at 37 weeks. But if not, then 38 to 40 के बीच में is the ideal time. How do you deliver them? What is the mode of delivery? Earlier, it was said that cesarean section would be an ideal idea, but nahi. Nowadays, it has been shown that cesarean section will in fact increase the risk of developing infections and venous thromboembolism. Wound के infections, puerperal sepsis will increase when you do a cesarean section, and hence a vaginal elective cesarean section is avoided and a vaginal delivery is preferred for these women. Apart from that, in women who have had history of avascular necrosis of hip, जिनका शायद hip replacement हुआ है या फिर उनका avascular necrosis of hip की वजह से they are unable to have the proper abducted lithotomy position for birth, they need special setup to keep their limbs straight and be able to deliver vaginally. So consideration has to be given to that by talking with the orthopedic surgeon. Apart from that, very basic, they have to deliver in hospitals. There is no possibility of these patients delivering even in lower centers. These patients with sickle cell disease have to be delivered in tertiary care centers. Blood should be ready, multiple bags should be ready for their delivery. Apart from that, they have to be given adequate fluid during labor. Fluid के टाइम वो खाते पीते नहीं है, तो उसकी वजह से उनको nil by mouth होने की वजह से there is a risk that they can have painful crisis. तो वो नहीं होने देना है. They have to be given adequate amount of fluids. Continuous intrapartum fetal heart rate monitoring has to be done क्योंकि ये babies are already hypoxic. They can succumb anytime during labor. Already because of all these blockages, उनका blood supply is impaired. So whenever there are contractions, the blood supply stops even more. They anyway have a very low reserve of their own of oxygen because of the blockages that were there since day one of pregnancy. Hence, these babies will not really tolerate labor very well. Hence, continuous NST का मशीन, CTG का मशीन लगा के रखना है. बीच बीच में FHS नहीं सुनना है, कंटिन्यूसली लगाते रहना है. Apart from that, they have to be offered anesthesia. If possible, epidural देना है, और अगर cesarean करना ही पड़ा then regional anesthesia, which is spinal anesthesia, is preferred. After delivery, you have to understand that these women, there is a almost 25, so 1 in 4 women will have a acute painful crisis. So hydration and oxygenation post-delivery should be maintained and they should be mobilized immediately after delivery within 6 to 7 hours. Apart from that, you have to understand that breastfeeding के time पे you should not be giving any opioid because this will lead to withdrawal of the fetus. It can lead to baby में narcotic syndrome. Opioid withdrawal हो सकता है. So the baby will become dependent on those opioids. So you have to avoid giving any possibility or any opioid. जितना हो सके उतना NSAIDs दिया करो. That is safe. NSAIDs are recommended and they are safe in the postpartum period and can be given in breastfeeding. Opioids are supposed to be avoided. Apart from that, if the baby has a possibility of having sickle cell disease, then he has to be tested. He or she has to be tested for that. Anti-thrombotic stockings have to be given to all the women. Pneumatic compression stockings have to be given, and thrombo prophylaxis to definitely dena hai until 6 weeks after delivery. Regarding contraception, which contraception is ideal? We all know that for patients with seizure episode, convulsions, and sickle cell disease, progesterone only pills and DMPA. Basically, progesterone is a very good modality because it reduces the chances of getting sickling episodes, acute painful crisis by almost 80%. So these women are very good candidates for receiving something like DMPA or Mirena, that is levonorgestrel containing intrauterine device. Oral contraceptive pills, combined contraceptive pills can be given, but the problem is these women are often having cardiovascular risk factors or they have history of stroke or painful crisis. ये thrombotic factors के वजह से they are getting contraindicated in women, but in women who have a very clear history, they do not have it. They can be given, but it has to be given after 6 weeks. Whereas all these progesterone वाले things can be given immediately after the day of delivery, whereas estrogen वाली चीजें have to be given after 6 weeks of delivery. Finally, the last part of the discussion कि क्या क्या करना है. Just something that we have already read about in the first appointment, you have to review the partner का क्या आया है, partner को ये बीमारी है या नहीं. You have to ask for it. You have to assess the female's eyes. You have to do a 2D echo and you have to review the medicines that she is taking. You have to stop angiotensin receptor blockers. You have to stop ACE inhibitors and you have to stop hydroxyurea. Ensure that she is taking 5 mg folic acid and antibiotics, that is penicillin if required. If not vaccinated, vaccinate her immediately. First visit में midstream urine for culture. So basically you have to send a urine culture in the first visit. Apart from that, from 12 weeks of gestation, you have to start them on aspirin and vitamin D as we have discussed earlier in doses of 5 to 10 microgram per day. From 16 weeks, you have to start doing every monthly midstream urine ka repeat culture. So urine culture and urine routine microscopy has to be done every monthly. So 16 के बाद में तुम देखोगे कि 20 weeks पे we have done MSU again. We have done again 24 weeks पे हमने किया है, फिर 28 weeks and then again 32 weeks पे किया हुआ है and finally 36 weeks. So every 4 weekly यानी monthly you have to check her urine for urinary tract infections. यूरिनरी ट्रैक्ट इन्फेक्शन बढ़ते क्यों है क्योंकि एनीवे देयर इज यूरिन रिटेंशन इन वुमेन हु आर प्रेग्नेंट. उसमें बिकॉज ऑफ impaired immunity they have a very high chance of developing urinary tract infection which can even progress to acute pyelonephritis wherein a female can even die because of pyelonephritis. So ये अवॉइड करना है. Apart from that, a detailed ultrasound monitoring has to be started from 24 weeks of gestation. So 24 के बाद 28 पे हमने वो किया, 28 के बाद हमने 32 पे किया. So बेबी का ग्रोथ मंथली कैसे हो रहा है वो देखना है. फाइनली फुल ब्लड काउंट भी करना है ऑन अ मंथली बेसिस. फुल ब्लड काउंट और CBC has to be done to check whether she is having anemia. Now these women, because of iron overload, you cannot be giving them excessive iron supplementation. In the entire chapter I never mentioned that these women should receive excessive iron. उनमें अगर iron deficiency रहा, once you have studied the iron profile of that female, then only give them iron supplementation. Otherwise, do not give them an overload of iron. You can just give them multivitamins. And finally, from 28 weeks of gestation, you have to assess the risk factors and she has to be started on injection LMWH as per her weight. And hence, that ends our topic today on, you can take a screenshot of this. This ends our topic of sickle cell disease. I hope this guideline was enough to explain you all the complications that can arise from sickle cell disease in pregnancy. I shall see you next week. As I've promised, it will be a chapter, it will be a discussion on beta thalassemia in pregnancy. And do make notes of this chapter. It is something that because you don't see these patients every day, it is easy to forget this chapter and the guidelines. So make notes and regularly revise them. Thank you. Signing off, Dr. Aditya. I shall see you next week.